Dr. Krista Casazza. I have a PhD in nutritional biochemistry, and my work is largely affiliated with the International Niemann-Pick Disease Registry and other Niemann-Pick disease type C patient advocacy groups, including the Era Precision Medical Research Fund. Niemann-Pick disease is a genetic, rare, highly heterogeneous disease. It's progressive. It's a lysosomal storage disorder characterized by a dysfunction in NPC1 or NPC2 proteins. And that leads to the accumulation of multiple lipid species. Most relevant is the inability to remove cholesterol from the cell, so that it accumulates in the lysosome. Particularly, the cholesterol derivative is 24-hydroxycholesterol. Because of the proteins, compromises the ability for CYP 46A1 to metabolize the cholesterol. And so it causes the accumulation of the cholesterol. There's a broad clinical spectrum. It ranges from rapidly fatal right after birth condition to an adult onset chronic, largely neurodegenerative disease. It's a rare disease, again, as I said. So the estimated rate is 1 in 120,000 live births. And again, it's heterogeneous. The clinical presentation is, it's based on kind of when the onset and the extent of the neurological involvement. But what we see typically is the loss of swallowing, speech, and motor function. And we have been kind of aware of the progression and the heterogeneity and the severity for several decades. And while there was recently in September of 2024 approval of 2 treatments, they treat some of the symptoms. There's still not an overarching, highly effective treatment that stops the neurological progression. So the treatments do extend the quantity and in many aspects the quality of life, because it treats the symptoms. But for the most part, there's not a cure, and there's still a difference in the treatment response, highlighting the need for identification of biomarkers to better target the CNS progression and be able to delay or prevent that CNS progression. The NPC community, very motivated by the current treatment options, and there's additional treatment options continuing to try to be discovered. The NPC community is very unified. There are, international, as I mentioned, the International Niemann-Pick Disease Alliance and the registry that's associated, Niemann-Pick UK, as well as some of the national, including the Era Precision that's housed at Notre Dame, strong NIH presence with Denny Porter and Liz Barry Kravitz at Rush University, Stephanie Colonia, who's working on some great assays to help develop the biomarkers, and the National Niemann-Pick Disease Foundation, as well as many of the industry stakeholders, including those with current treatments. That's Zevra, Intrabio, as well as some that are developing treatments. So, this unified vision towards continued improvement in treatment and hope for an ultimate cure or combinations of treatment that may come close to curing or at least preventing and delaying the CNS progression has really come together to be able to try to identify, either a validated, qualified set of biomarkers or even reasonably likely surrogate endpoints to progress or accelerate drug development to improve treatment options. And so what the paper kind of goes over, the recent review, is some of the key candidates that would likely, because, I mentioned we have different treatments, and, the efficacious or effectiveness is differs. And also there's some aspects of combination therapy, being that arimoclomol is often taken with miglustat. CHMP just recently suggested or encouraged miglustat, and then some of the other aspects of cyclodextrin that are in process those aspects in order to really have a comprehensive outcome improvement, that it's likely that we may need a combination of treatments. And if that's the case and we're hitting different targets with different treatment options, then it's really essential that there's biomarkers that can assess the rate of progression, or, if you think about the best criteria, if you think about the diagnostic aspects, because early diagnosis leads to better treatment outcomes. We think of progression and how we can look at response to treatment or monitoring, then there's probably going to be a suite of biomarkers. And so that unified community is taking different perspectives to identify these biomarkers. And so, continuing the unified approach in which we can really hone in on what we're trying to measure and include biomarkers in clinical trials and again, with data sharing across the stakeholders. But that being said, probably to date, what we've demonstrated in the review is that there are some candidates that have more clinical evidence that support candidacy for biomarker. And as I mentioned, 24-hydroxycholesterol, it being the key metabolite, if we can identify or measure it as a biomarker as it exiting the cell, that means it's not being trapped in the cell or in the lysosome. So we know that the treatment is allowing for the cholesterol to be metabolized and exit the cell. And so that gives us some aspect of the approach towards normal functioning of cholesterol metabolism. So that's looking at kind of the metabolic aspect. But if we look at some of the CNS aspects in terms of what is happening within the central nervous system, particularly in the brain, of the key two biomarkers that we've looked at, and again, Stephanie Colonia has done a lot of work with calbindin D and that assay and developing that assay. Calbindin D is, it's within the mechanistic underpinnings of the Purkinje fibers and Purkinje cell death. And so some of the dysfunction, we can measure that the degree or the extent of Purkinje fiber and cell death by measuring the levels of calbindin, again, to see, kind of the cytosol, how the calcium buffer is occurring in the Purkinje fibers and the concentrations. And so the reductions in calbindin D have been observed in CSF in terms of the onset of ataxia, so indicating neurologic disease progression. So calbindin D is really in terms of the progression of the disease. And we're really trying to develop, again, different biomarkers to see if we can halt that progression, because while we can treat the symptoms with some of the current treatments, we really want to ensure or identify a way to measure if we're halting the CNS progression. And another key biomarker that's kind of more of an agnostic biomarker, but seems to be highly relevant in NPC is neurofilament light chain, or NFL. And you probably are familiar with that from some of the ALS SOD1 work, and it was qualified as a biomarker for the specific SOD1 mutation in ALS as a prognostic biomarker, because it represents a measure of progression or delay of progression of the disease based on neuronal injury. So NFL is released when there's neuronal injury. And so if we're seeing a decrease in NFL, we're seeing the injurious aspects likely related to neuroinflammation is being decreased. So NFL is also a candidate. And I mentioned both the Purkinje fiber cell death as well as the neuronal injury. And a lot of that is key related to neuroinflammation. So continue to look at other aspects of neuroinflammation also are important aspects, but those are secondary or downstream effects. So we're trying to look at the candidate biomarkers and what's occurring upstream and downstream of those, focusing on potentially a suite of biomarkers. And again, when I say we have a really strong community presence that is really dedicated to taking a unified approach to identify a biomarker or set of biomarkers that will help to accelerate continued drug development, combination drug development, or other aspects for the improvement of individuals living with NPC and their caregivers.